Thank you, and I'm really happy to be here and to be invited by Professor Anna Flavia to speak. We've worked together for many years on the topic of violence against women and healthcare. So I've been here probably 4 times, and I always feel like this is like a second academic home for me. So thank you, Anna. So, first slide. Thanks, yeah. So the objectives today are firstly to sketch the current landscape and look at how different policies in the UK and research evidence have led to safe inquiry in maternity care for domestic violence and abuse, and different referral pathways for women. Second, I want to focus on the experiences of Black and minority ethnic and refugee women and their help-seeking experiences. And third, I'd like to pull out practical lessons that we've learned from the work that we conducted here in Brazil, but other countries globally that bear resonance for future UK research in this area. Next. I just put these 2 slides in today because I've been visiting many organizations with Anna during my week here, and I've been thinking about the similarities between the National Health Service in England and SUS in Brazil. So as you have here, we have a free National Health Service that was established in 1948. It's funded through taxation, and it's free at point of use. And there are some charges. For example, some people will pay for dental care or to see an optometrist. In terms of primary care, I think this is where I see the biggest difference. So in the UK, general practitioners are really the gatekeepers to more specialised services. And we don't have these big multidisciplinary teams that I see that you have here in your basic unit. So I see that you have social workers. Social workers are based outside of primary care in the UK. You have psychologists. We don't have that, clinical psychologists in our GP surgeries. So that's very different. And I think you have a much stronger sort of community orientation compared to primary care in the UK. And I think you also have longer in consultations. I think you have 15 minutes, and I think we have 10 minutes. So this is something. And also I think the role of the private sector. So I understand that you have private not-for-profit organisations. We also have this, that the NHS can buy private services to reduce waiting lists for things like hip replacement, cataract surgery. But, you know, there are pros and cons to having this kind of model as there is in Brazil. And something I didn't know about, and I only learned about it during this visit, is that actually we are drawing on some successful health models here. So we don't have community health workers in the UK in primary health care. But there have been some pilots of what we call community health and well-being workers in different parts of England. And they are sort of, you know, they're not clinicians or healthcare providers, but they do receive training. They could come from the voluntary sector or other services. And we have something called social prescribers. It's kind of like a community health worker, so they work with people in primary care that maybe they have depression but not serious, they might have financial debt, you know, housing issues, and social prescribers try to connect those people to services. And the community health and well-being workers are not trying to replace those, they're an addition to our social prescribers. And there has been an evaluation of these community health workers in Cornwall, and it found that it's important to use locally trained people so that they build trust in the community. They live in those communities where they're working. They have their own household list, and they are embedded in the primary healthcare centre, so they share the space. They're trained. They have supervision. So they do this kind of door-to-door, what we call light touch outreach, and the more complex cases go to the social prescribers. But still there's a need for the community health workers in the UK to have very more defined roles. Okay, so let me start the talk. I thought it would be good to give you a definition of the terminology. This is the Home Office definition of domestic violence and abuse, which they describe as a pattern of incidents of controlling or coercive behaviour, of threatening behaviour. And this is abuse that takes place in the family or in the household. It can be between partners, it can be between family members, and it's regardless of gender and sexuality. And, you know, it also includes other forms of abuse like female genital mutilation and what we call so-called honour-based violence in the UK, which is quite common in our Asian communities. So in maternity care, actually, you know, a healthcare provider might see any types of these violence. Right, so here I just wanted to situate domestic violence and abuse, which is between household and family members, within the broader category of gender-based violence. So that would include things like FGM, sexual trafficking, honour-based violence. And so intimate partner violence is one form of domestic abuse. This is the definition of ethnic minority in the UK. So black and minority ethnic, it stands for black, Asian and minority ethnic, and it's defined as all groups except white ethnic groups. It's not related to country of origin, so it can include Gypsy, Roma and Irish travelling communities. And the term minoritized ethnic is there to kind of signal that this isn't about characteristics, it's about inequalities that are embedded in structural issues. Okay, so the scale of domestic violence and abuse in England and Wales is quite significant. So millions of adults experience this every year. And this graph depicts the prevalence of different kinds of abuse and assault experienced by men, women, and everybody since the age of 16. And so you can see that there's clearly a gender asymmetry because women are experiencing, they have a higher prevalence of all those forms of violence, including domestic abuse, so over 25% ever. And then if we look at the prevalence among black and minority ethnic women in the past year, it's a bit more of a complex pattern. So you can see that women of mixed ethnic origin have experienced more domestic violence and abuse in the past year. Asian and black or black British women, the lowest rates, and white women somewhere in between. So as I said, there is this gender asymmetry. You know, women are more likely to be injured as a result of the violence. They're more likely to need hospital care. They live in fear of the violence and more likely to suffer sexual abuse as part of that violence. And I wanted to just look at the prevalence in Western Europe in the context of other WHO regions. So you can see that, so the red dot is in the past 12 months, the prevalence of intimate partner violence, and the orange dot is the lifetime prevalence. So you can see that Western Europe and Latin America are kind of on par, and there are higher prevalences of intimate partner violence in, for example, the African region, and regions where there are more deeply entrenched gender norms, harmful gender norms that reinforce violence against women. And so thinking about these very different contexts has implications for the types of interventions that can be developed in health systems. And, you know, the figure overall globally, it's 1 in 3 women globally have experienced intimate partner violence or non-partner sexual violence. So this diagram depicts the direct and indirect pathways to the harmful impacts of intimate partner violence. So, you know, physical violence has a direct impact on injuries. It can create somatic conditions like chronic pain. But, you know, psychological stress and fear can cause women to have mental health problems. Perhaps they will delay care and not attend the healthcare facility. And these are just all the figures from the WHO report. So 42% of women who've experienced physical or sexual violence have injuries. They're twice as likely to experience depression, twice as likely to have alcohol use disorders. 16% have a low birth weight baby, 1.5 times more likely to acquire HIV, and they're 4.5 times more likely to attempt suicide. So why does this matter in maternity? So if we look at the UK, the prevalence of domestic violence in pregnancy based on a number of UK studies is somewhere between 3 and 6%. And some people say, oh, that's low. But if you have a maternity care service where there are 5,000 to 7,000 women going through a year, that could be 300 to 400 women who are experiencing violence in pregnancy and having maternal health complications. So it's a period of increased vulnerability for women. So they're more physically vulnerable, they're emotionally vulnerable, they may stop working, they become more reliant on their partner financially and physically. So we know that it has adverse impacts on maternal and neonatal outcomes. And actually maternity is a really key entry point because in the UK, women see a midwife and a team of midwives during the antenatal period and postnatally as well for 10 days. So it's an opportunity where they have repeated contact, they can build trust, and it's a chance for midwives to identify any violence that the woman is experiencing and offering support. I just wanted to talk a little bit about Black and minoritized ethnic women because it's not just about the abuse. They're experiencing other compounding factors which make it very difficult for them to even think about seeking help from healthcare or anywhere. So if they have insecure immigration status, you know, they might be afraid to report anywhere, and perhaps the abuser is actually using that as a tool to control and further abuse by telling them if you tell anyone, you'll be sent home, or something like this to make her very afraid. Some women, depending on their immigration status, won't have any recourse to public funds. So the other issue is in the NHS, I mean, this doesn't happen all the time, but sometimes family members are used as interpreters, and that can be very dangerous for women who are experiencing domestic violence. And a report by IMCAN recommends that advocacy services should be provided, they should be culturally specific and be provided by the people, by Black and minority ethnic women, to build trust within the community. So I wanted to do this kind of trajectory of policy and practice, and I guess the modern story of maternity care responses to domestic violence in the UK started with this first confidential inquiries into maternal deaths. So this is a report that comes out every 3 years. It looks into the causes of maternal deaths. It's not a witch hunt, it's not about blame, but looking at where we can improve practice. And this was the first report to identify domestic violence as a cause of maternal death. Following on from that, the Royal College of Obstetricians and Gynecologists formed a violence against women study group, and which really kind of focused on the need for a clinical response. There were a number of other confidential inquiries that highlighted other issues of poor practice, as I said, women experiencing domestic violence where professional translation services were not used, or where women were not attending for care and they were not being followed up. And then the Royal College of Midwives, they produced a position paper in 2006, which was the first time there was a kind of guideline for midwives. So these newspaper cuttings are just before I started my PhD, which was on this topic of domestic violence in pregnancy. And you can see that there was a lot of caution about involving healthcare providers in supporting women who are experiencing domestic violence in pregnancy. So you can see on the right, this person, who I think is from an NGO, said that routine inquiry may lead to women being kept away from doctors or partners for fear of being found out. So it basically says that routine inquiry can do more harm than good. So this was the kind of context in which I was trying to begin my PhD journey, which was actually, you know, it was a little bit intimidating because it was the first study in the UK to train midwives to ask routinely about domestic violence in pregnancy and provide support to women. So out of that climate, we implemented the first UK study to train midwives to ask routinely about domestic violence and abuse. So we were working in 2 London teaching hospitals in the southeast of London. And so midwives were trained to ask women at 2 time points in pregnancy, at the first appointment, the booking appointment, around 36 weeks, and then once postnatally. And then they had, if a woman was identified, they would then refer the woman to the local domestic violence service. The midwives were supported by me and another research midwife. 892 women were asked on at least one occasion, and 2.5 reported domestic violence in pregnancy. And you can see the prevalence identified when midwives were asking at the different time points. And we wanted to compare this with how much domestic violence was found in the past. So we did a review of maternity case notes And out of 265 records, we found one case. Now, that's documentation, which is another issue. It doesn't mean they found one case, but only one case was documented. So we worked with local women's aid and specialist services, and a key powerful message from that study, which is still relevant today, is that women find it acceptable if a trained midwife asks them about domestic violence in a non-judgmental, empathic way, in a safe environment as well. We found that midwives, they supported this practice, but many found it difficult because in the UK, partners are very involved in maternity care, and so it was very difficult to sometimes separate women from their partners, or if there was a very overbearing partner that was present during an appointment, it was then difficult to get time alone. They'd say, "Why do you want time alone? Why can't I be involved?" And also, it was very difficult to ask women postnatally at home. It just didn't seem like a legitimate place to ask, and midwives said they felt like a guest. We also conducted a survey with the midwives because we know that in an all-female profession, there's going to be high levels of domestic violence. This was something that we did find, and that many midwives reached out for help as well. And the one thing that came out of this was midwives suggested that there needs to be someone on site, a specialist or someone trained up who they can refer to within the healthcare setting to get advice about a case, or for the woman to see someone, a bit like how you might have the NPV in some of your healthcare facilities. And so this was a really powerful quote that I found. A midwife said, "Don't just tell me to ask, help me to help her." So really this project, the Mosaic Women's Wellbeing Project, was the next logical step after that study. So it came directly out of the midwife's suggestion that we have a specialist on-site person. So we worked with the same NHS trusts, but an NGO called the 170 Community Project. It was based in the southeast of London, which is an ethnically diverse setting with Black African and Black Caribbean women. It also had a growing Latin American population. We developed clinical guidelines for the service, and midwives had a mandatory study day. So in the UK, midwives have to do a set number of study days to keep their license, and the Director of Midwifery made domestic violence one of the mandatory study days. We also implemented this in the sexual health clinics. There was a policy on offering women confidential time during their care without the partner present, so that they could discuss any issues around violence. And in the UK, women carry their maternity notes. So we had to make a very discreet code in the notes to be able to indicate to other midwives that this woman has been asked and there is domestic violence. But there was also a separate system for confidentially documenting the violence. And women who were identified as experiencing a partner abuse were referred to a Mosaic domestic violence advocate from the NGO project. Now, the Mosaic advocates were based in the hospital, so it was very easy for women to access them without raising any suspicion within their family or with their partner. They could just say, "I'm going to this women's wellbeing project." Okay, so the evaluation found that training and having the on-site advocates really led to a shift in midwives' practice. Having the advocates on site made them more confident and ready to ask about violence. And during the time of the project, the rates of routine inquiry in the maternity service rose from 15 to 47%, and it stood at 58% in the sexual health clinic. Again, midwives said it was quite challenging to get confidential time with women away from partners and family members. And most of the referrals to Mosaic came from maternity, so 63% from maternity, 7% from the sexual health clinic, and 30% from other departments in the hospital. So looking at the views of women who used Mosaic, so it really provided a safe space for women to discuss their concerns. And during the time of the study, Mosaic saw 156 women, mostly young women, many black and minority ethnic women who were British nationals. We did a survey with a small number of women to look at some outcomes like the violence and mental health outcomes. And we found a reduction in the levels of violent and controlling behaviours after 6 months, and a significant increase in women's self-esteem and reductions in anxiety and depression, but also increased self-efficacy. In our survey of midwives, 40% reported experiencing domestic violence at some point in their lives, and we know that some midwives weren't really able to engage in asking women because the violence was very current and they were seeking help from Mosaic. We had an economic evaluation, and it showed that it was repaid more than twofold, largely in terms of reduction in the pain and suffering of women in less than 1 year. So we did some qualitative interviews with 34 women who received help from Mosaic, and just over a third of those women had insecure immigration status when they were referred to Mosaic. So they had a lot of fear about talking about the violence to professionals because they thought their data would be given to the Home Office and that their application to have indefinite leave to remain in the UK would be rejected. Partner would give women the wrong information as a way to control them and keep them at home. And, many women said they would not report to the police. Eligibility for help can depend on immigration status. So in the UK, if you're a refugee or you have an application for asylum, there is an act which allows women to have recourse to public funds. But there are other categories. For example, if you've overstayed on a visa, for example, a visitor visa, where you would not have recourse to public fund unless you were pregnant and the father of the baby was a UK citizen. So by the end of the study, 3 of those 12 women later secured indefinite leave to remain under the domestic violence concession, and only then could they leave their partners. So I just wanted to give a couple of quotes, and I like this quote. The woman says, he's always telling me if you call them, they'll start asking you questions. But when I finally called the police, they said, it doesn't mean that because you don't have status in this country, you should go through things like that. And I think this quote is quite powerful because it shows how a first response can be really helpful to a woman and help to open up communication and build trust. And then this one, the woman says, all the different agencies don't work together. It's like pass the parcel. We've got you through stage 1, now you're on your own. So there's no complete system where someone can help you all the way through. And I chose this one because Anna and I have been talking about multi-sector work and how it can be very fragmented, and it's the same in Brazil as it is in the UK, that it's very difficult to make multi-sector work for women so that they don't feel abandoned at any point in their pathway. So then this shows policy and practice from the early 2000s to today. So we have multi-agency risk assessment conferences in the UK. That started in 2003. And that's a multi-professional group. It will have the police, healthcare providers, education, social workers. And this is really to meet to discuss cases of domestic violence of women who are at severe risk. We also had the domestic violence homicide reviews. Again, it was a way to review the services that women were involved in and identify areas of poor practice. The current guideline for healthcare professionals, which recommends that healthcare providers ask about domestic violence, is the National Institute for Clinical Excellence. And that also talks about the need for strong multi-sector work. The 2021 government strategy to tackle violence against women and girls showed investment in something called independent domestic violence advocates, which I'll talk about. And the latest strategy from the government has promised to, or they're committed to halving violence against women and girls within a decade. So these independent domestic violence advocates, and I've been discussing this with Anna and her team, they are based in healthcare. They have to receive training. They get ongoing training as they are in practice, and they provide emotional and practical support to service users experiencing domestic violence and abuse. So they could be based in maternity care, they can be based in accident and emergency settings. And a survey of UK maternity trusts found that 69% had a health IDVA program in place. It's not without its problems. So there are a lot of things that can support the implementation. For example, you know, it's important that NHS staff understand the role of the IDVA. They need to have communication with trust staff, and some of the barriers are, you know, lack of private space for working. So I just wanted to mention briefly this study that we worked together with Brazil and partners in Palestine, Sri Lanka and Nepal, and it was looking at strengthening the healthcare response to violence against women. And these are the key lessons that we learned from that, which I think we need to take away in future research in the UK. First, the importance of health systems thinking and theory-informed interventions. So actually moving away from looking at just individual healthcare provider or clinics. The need for targeted interventions for mid-level managers, because they're the ones that drive organisational change and can monitor the implementation of these interventions. The need for a very strong women-centred perspective in training programs that have gender lens embedded in them. The need to expand referral and support options for women who are going to be at various stages of readiness to seek help. So not all women will follow up on referrals. And lastly is to strengthen the healthcare's connections to other sectors. So a question that I'm going away with when I leave Brazil tomorrow is how can we strengthen multi-sector working? Thank you.
Gente, por conta do horário, nós vamos permitir apenas uma pergunta. Então, se alguém tiver 3... Ok. 3 perguntas. Então, por favor, levanta a mão que eu levo o microfone até você. Tá. Se você quiser perguntar em português, temos Yara, que pode traduzir, e a professora também. Alguém tem alguma pergunta? Você tem? Por favor, no microfone. Isso aí funciona? Inglês.
Hi, Loraine. Thank you so much for your presentation. You said that Black and Asian women had a lower rate of violence reported than white women. And I was wondering, did you investigate if this has to do with the violence or with the reporting? Because I was very curious.
I think, these figures come from crime statistics in England and Wales, and that has 2 parts. It's based on a household survey and police reporting. So I think it has to do with low disclosure, but also there were very small numbers for past year prevalence. So, mixed ethnic women, it was highest, and kind of within that group, because there are lots of categories within that, women who were white and Black African or Black Caribbean, they had the highest rates, from what I understand.
Congratulations, Loraine. I have a question. I'm curious about if you have any data about third-part violence against women. We talk a lot about intimate part violence, and I'm working now with data from third-party and community part violence against women. Do you have any data about this?
Not in this study. Who would be the aggressors in this case?
The state, community policies, at work, any kind of violence that does not come from the intimate partner. Because we have this idea that pregnancy might protect women. We have seen a lot of evidence that is not totally true, considering the partner. But I'm curious about the society. How does society see the pregnant women?
Yeah, I mean, this isn't research that I've conducted, so I don't have any data, but I think there are kind of layers of violence. So this kind of structural level violence, state level violence. So for example, let me talk about the HERA study, and also maybe Anna can talk about Brazil. In Palestine, when we were working in the health clinics, you can see the interaction between violence that happens as a result of the conflict and the occupation in Palestine and women's experiences of intimate partner violence in the home, because women are very afraid to report and seek help from the clinics because, for example, in Palestine, the family is a really important source of resilience for Palestinian people. But for women, it's also a source of oppression if they're experiencing violence from their partner. So they have this predicament that they're in. And also for the healthcare providers, many of them were quite afraid to ask women about violence because there wasn't any police protection in certain areas. So they have areas A, B, and C. So I think you can see this overlap. And, the violence, the origins of the violence, from our study, we can see that men feel very emasculated under the occupation, and they have no power, and maybe they see their only power is in the home, and they're misusing it by being violent towards their partners or children. And I think for Brazil, I prefer Anna to speak.
Não, aqui no Brasil, a gente vai até uma das coisas que a gente fez essa semana foi pensar em fazer um paper junto com a Palestina, porque tanto na Palestina quanto no Brasil existe essa questão de que a polícia e a justiça não são, para várias pessoas da comunidade, o lugar mais seguro. Então, aqui no Brasil, em comunidades dominadas pelo tráfico, não é possível a denúncia, e as mulheres temem muito a violência policial contra os filhos, os maridos, e também a violência do tráfico, né? Se elas reportam à polícia, ou mesmo se o tráfico ficar sabendo de familiares delas violentos, né? Mas quando a gente fez o estudo lá atrás da OMS, a gente perguntou por parceiro íntimo, doméstica e outros agressores, né? Eles eram relativamente pequenos, Faisal, mas a minha aposta é que deve estar aumentando, porque quanto mais as mulheres ocupam os espaços públicos, mais violência elas sofrem na universidade, no trabalho, no transporte, né? Então, se você está só dentro de casa, você sofre basicamente violência doméstica. Mas se você circula na comunidade, a questão de gênero segue, né? E a gente acaba sofrendo violência de outros agressores. Quando a gente fez na OMS, as mulheres aqui em São Paulo sofriam o mesmo tanto de violência das mulheres da Zona da Mata de Pernambuco. Na Zona da Mata de Pernambuco, a violência por parceiro íntimo era muito mais alta que aqui em São Paulo. Mas aqui em São Paulo, a violência por outros agressores era mais alta, porque as mulheres circulam mais. Então, as mulheres são vítimas de violência dentro e fora de casa. É que a violência doméstica é tão grande, né, e é por parceiro íntimo, que acaba obscurecendo, eu acho, né, essas outras formas de violência que, às vezes, são mais sutis também. Assédio sexual, assédio moral, importunação sexual, né, na forma de... E estupro, claro, né, mas, vamos dizer, nos ambientes de trabalho, de escola, de transporte, são violências que parecem relativamente, né, mais leves, fora o estupro, não é tanta violência física, mas é uma combinação, né, de várias formas de violência, quando a gente é menina, adolescente, adulta, dentro de casa, fora de casa. Então, às vezes, eu que trabalho também aqui com a violência na universidade, né, às vezes um assédio sexual por um orientador ou um assédio moral por colega tem um efeito devastador na pessoa que já vem de um histórico de violências anteriores. Então, a gente também tem que levar em consideração esse caráter dose-resposta, né, cumulativo da violência, que às vezes faz com que algo que pode parecer a olhos externos relativamente leve, ou uma cantada mal dada, para a pessoa tem um efeito de evasão, por exemplo, escolar. Então, acho interessante a gente estudar esses efeitos aditivos entre as várias formas de violência de gênero que todas as mulheres sofrem, e algumas mais, outras menos, né? Quanto mais vulnerável.
Mais uma última pergunta. Romênia, do teu lado.
Não é uma pergunta, é mais um comentário mesmo. Eu sou estudante de odontologia, eu faço parte de um grupo que chama GPEC, Grupo de Estudos e Pesquisas Qualitativas, e dentro desse grupo a gente tem o GT Vida, que é coordenado pela professora a doutora Luciane. E a gente começou a estudar também violência. Por que a gente começou a estudar violência? A gente foi fazer uma revisão da literatura, e dentro dessa revisão da literatura a gente descobriu que a violência doméstica, quem está praticando a violência sempre vai ter como foco destruir a identidade da vítima. E a identidade da vítima é região de cabeça e pescoço. Então, o dentista é o segundo profissional mais procurado, mais acessado por essas vítimas de violência doméstica. Só que quando a gente foi fazer uma pesquisa para saber a notificação compulsória, quem estava realizando, o dentista era o profissional que menos realizava a notificação compulsória. Então, o nosso grupo começou a trabalhar, a fazer diversos estudos, e a gente percebeu que dentro da graduação, dentro do ensino da odontologia, não tem discutido, não tem falado sobre violência sendo que o dentista é o segundo profissional mais acessado. Os estudantes da Unicamp e da Universidade da USP, eles não sabem nem o que é notificação compulsória. E, a partir disso, o nosso grupo criou uma cartilha junto com o Ministério da Saúde, que vocês podem acessar, está disponível na BVS, que é a Equipe de Saúde Bucal em Enfrentamento das Violências. E são déficits bem grandes que existem dentro do ensino. A gente até tentou trazer uma proposta para o SIMCOL, mas acabou não dando certo porque as pessoas que iam trazer a proposta tiveram outro compromisso dessa deficiência que existe dentro do ensino da odontologia. O cirurgião dentista é um dos profissionais mais acessados por vítimas de violência, mas ele não sabe nem o que é violência. Por quê? Porque a prática é tão biomédica, ele é tão focado ali no dente, no milímetro da raiz, que ele não olha para todas as outras coisas que atravessam o consultório.
Bom, com esse último comentário, que eu acho que foi mais um comentário, nós damos fim à nossa palestra. Muito obrigado, professora. Uma salva de palmas para ela, por favor, gente.